Things that I'm going to talk about in this talk are going to be so use of primary staging and use of PSMA for detection of sites of recurrent or metastatic disease. And those are really the labeled indications. So those are appropriate. And I'm going to, I guess, try to structure things as to how they evolved in real time. So sort of phase 2 single center trials that we're trying to understand how we would use these. And then most of the data I'll present, just because it's what I know best, are the POLARIFY pivotal trials and what those mean for us and how we should approach the scans. I do have a few disclosures, probably the most relevant one being some associations with Progenics Pharmaceuticals, who are the owners of the intellectual property behind POLARIFY. All right, so prostate-specific membrane antigen, if we break it down to just a few key notes about it, it's a transmembrane carboxypeptidase. It's highly expressed on prostate cancer cells. Not all prostate cancer cells. It's about 96% of tumors will have significant PSMA expression, but that is variable at the cellular level. There's frequent expression has been observed in prostate cancer tumors, and then there's a direct correlation between expression levels and tumor aggressiveness. That's at least at the histopathologic level. I don't know that we always see that on the scan. PSMA, again, transmembrane carboxypeptidase has a large extracellular domain, and there are several sites on that we can leverage for binding of small molecules, antibodies, and other things for both imaging and therapy. And we know a few things about PSMA PET so far. At least I think we've established these as sort of truisms in the field. Moderate sensitivity but very high specificity for preoperative nodal staging. There's a high detection efficiency for sites of biochemical recurrence, and the PSMA PET's effective for guiding focal therapy or metastasis-directed therapy in sites of disease outside of the prostate, and selecting patients for PSMA-targeted radiotherapeutics, which we'll talk a bit more about on Sunday morning. All right, but again, let's, as I said, sort of single center phase 2, and then we'll look at the kind of more pivotal trials that grew out of those things. So these are a couple of patients that both enrolled in a trial we did a number of years ago that all these men had what was believed to be clinically localized, very high risk prostate cancer. So if they had anything that was an obvious metastasis, they weren't enrolled in this trial. An obvious metastasis based on, at the time, conventional imaging, which would be, for most of them, CT and bone scan. And so both of these gentlemen would have been essentially clinically the same. They both had Gleason 8 disease that was thought to be confined to the prostate. They both underwent radical prostatectomies with extended pelvic lymph node dissections. But the guy on the right had an immediate biochemical failure. And had this been an unblinded trial and had our surgeons been able to use the information from the PSMA PET scan, which was very, very investigational at the time, they would have known that he had already systemic nodal disease. And I think would have probably offered him a different therapeutic approach. So PSMA PET gave us the power to tell what the difference was between these two gentlemen in a way that conventional imaging couldn't. And ultimately, that sort of thought process has now led to several pivotal clinical trials across different radiotracers. But one of them was the Osprey trial, and we'll only talk a little bit about Osprey cohort A. That was the sort of scan and resect preoperative staging protocol, and Osprey was powered to two primary endpoints. And they were both relative to nodal disease in the pelvis, and that was sensitivity and specificity relative to histopathology. The FDA was not particularly concerned about what was going on in the prostate because we already knew from biopsy that these men had high risk or very high risk disease. So they said, we don't really see what the added value is of re-imaging the disease that we already know about. I'll show you a little bit of data, though, that may be of interest to this group in particular about that intraprostatic information that we get. But if we look at the Osprey results relative to those co-primary endpoints, the sensitivity and specificity for detection of lymph node involvement relative to histopathology, we see that, in fact, the sensitivity isn't that great. It's about 40%. So I think we should still view this as a disease that is surgically staged in terms of pelvic lymph nodes. The specificity, however, is incredibly high, so it approaches 100%. So unlike something like FDG PET, where you have all these nodes that you're always struggling. Is this cancer? Is this inflammatory? No, here it's really that sort of washes away, and we're left with a very, very high specificity. Post hoc analysis said that if you limit the analysis to only those lymph nodes that are greater than or equal to 5 millimeters in short axis diameter, your sensitivity goes up to 60%, which would have been the sort of predefined endpoint that had been decided upon with the FDA before this trial, but your specificity remains unchanged. that tells me as someone who's interpreting these scans is that I can drive my sensitivity to anything and my specificity is robust. So I read the parts of the pelvis that I think are sort of the danger zones: proximal external iliacs, obturator fossae, internal iliacs, maybe common iliacs, perirectal and presacral lymph node chains. I read those with incredibly high sensitivity because it seems like no matter what I set my sensitivity to, my specificity is unchanged. This is sort of not even on the press yet, but hopefully will be soon. So we did ask, okay, even if the FDA isn't interested, what can we learn, and are there good ways to segment tumors within the prostate? And we might think about this if you wanted to boost external beam radiation therapy. If you were going to do something besides sort of whole gland or hemigland ablation, would there be a way to be more focused on the tumor? And can we learn that from imaging? And so one of the most trod upon research fellows in history went through and took all these whole mount specimens and put them on 1 millimeter by 1 millimeter graph paper, and then transferred them on transparency, and then went through and counted every 1 millimeter square that had prostate cancer in it across 25 patients. Which I don't know how he kept his sanity doing that. And then we went back and we segmented the tumor in a bunch of different ways on the PET. And it turned out that an adaptive segmentation method where you take into account background and then set a threshold based on the maximum uptake in the tumor in combination with that background gave you the best recapitulation of a sort of millimeter by millimeter level volume of prostate tumor relative to histopathology. But I will also tell you the scatter plots for all of these things are kind of all over the place. So although on a population level that single approach to segmentation works, across individual patients it can be variable in how good it is. So this is an area where I am hopeful that AI is going to help us and help us understand how we should really segment these tumors. Because sort of a relatively blunt force approach that's right now very easy to clinically apply doesn't seem to work all that well. And this is just workflow, kind of what we did. Our radiation oncology group is trying to incorporate this a little bit into sort of boosting to certain areas of the prostate. But again, I do think we still have a lot of work to do to understand this. All right, so that was sort of primary staging, intraprostatic discussion, and then let's move on to detecting recurrent disease, because this has been, I think, the most common utilization of PSMA PET over the few years that we've had it FDA approved. At one time, I would have guessed somewhere between 70 and 80% of our PSMA PETs were done for this indication. I think we're starting to see more PSMA PETs done in the staging time frame, but still recurrent disease and recurrent disease to decide if men are salvage candidates, to decide if they have sites that we can carry out metastasis-directed therapy in a safe way. These are all things that PSMA PET has really opened up for us. Here's just an example of a local recurrence. So this gentleman had a radical prostatectomy. He had what looked to be a little area of uptake kind of poking out from behind the excreted urine in the urinary bladder. And this was also early days of PSMA PET. This is probably circa, 2016 maybe. And I was a resident, and no one believed me that this was a local recurrence. So, of course, the multiparametric pelvic MR was also performed, which showed an enhancing nodule there. So at that point, we became convinced, and we also became convinced that regardless of what's going on in the bladder, if we very carefully window our study and really kind of hunt these things out, particularly around the bladder neck anastomosis, we can usually find them. What's even more common than that would be 1 or maybe 2 pelvic lymph nodes. At least in our clinical practice, that's the most common pattern that we see. These are often 1, 2, 3 millimeter nodes. Hard to even see on the CT, much less call any disease in them on the CT. And so some data like that, and of course a massive amount of predominantly retrospective data from Europe that had looked at this space with primarily gallium PSMA-11 sort of led to what was eventually the Condor trial. Now this is a much more difficult trial to design than the Osprey trial had been, only because most of these patients were going to have findings that weren't necessarily biopsiable. They would be either too small or too subtle to sort of confidently target with something like a fine needle aspiration. So we knew that there had to be some other standard of truth besides just histopathology. But long and short of it, patients would get scanned, then they would sort of if they had a positive finding on their scan, it would go down this kind of standard of truth pathway that included histopathology if possible. But if histopathology wasn't possible, they could get confirmatory imaging. And interestingly, this is in sort of that window when Axemin was FDA approved, but PSMA PET wasn't. So they could get a confirmatory Axemin scan, and if it co-localized at least one of the same lesions as PSMA PET, that was considered to have met the standard of truth. And then lastly, and I think only one patient went down this pathway, you could have targeted radiation to visible sites of disease without starting systemic therapy. And if you had an objective biochemical response, that was also considered to have met the standard of truth. And I think there's really two key things that I think inform my approach to scans that came out of the Condor results. So one is that there is a pretty strong correlation between PSA level and lesion detection on the scan. That perhaps isn't surprising. Higher PSA levels should imply higher volume disease and should give us more confidence that we're going to see something on the scan. I do think that 36% is a little pessimistic. I think that's the vagaries of a multi-center trial. If you're really tuned in and you're reading your scans well and you trust your PET scanner and you have good communication with other folks that are going to use the information, I do think you can probably get that up to about 50%, but that's probably about as high as that sort of below 0.5 range goes. The other piece of data from Condor that I think is important was the actual primary endpoint of Condor, which is something called the correct localization rate, which was just the FDA's way of saying lesion level positive predictive value. The lesion level positive predictive value has a little bit of a trend towards being higher at higher PSA levels, but it's nowhere near as strong as the detectability trend. So what I think this all shakes out to is that you do want to know the PSA before you look at the scan. If the PSA is low, you should have an expectation that there's a good chance the scan won't show you anything. But if you see something that makes sense for prostate cancer, internal iliac lymph node that's 0.3 centimeters and has intense uptake. If the PSA is 0.3, I believe that that's a site of prostate cancer. If the PSA is 3, I believe that that's a site of prostate cancer, because their positive predictive values should be pretty similar. And of course, if we do believe that we have a high detection efficiency in the biochemical recurrence setting, we should be able to extend that to the idea of doing metastasis-directed therapy and trying to, if not give patients a second chance at cure, at least maybe kick the can down the road on them getting systemic therapy. Here's a patient who had a PSA of 3.9. He had a solitary visible site of disease on his PSMA PET scan. You can see it here is probably presacral or perirectal, whatever you'd like to call that lymph node. He underwent SBRT to that, did not start systemic therapy, and achieved an undetectable PSA. We followed him on our IRB protocol for about 2 years, and he remained undetectable at the end of 2 years. I consider that a huge win. Even if he eventually recurs, he still avoided all the toxicities of ADT for 2 years. There's also patients that we had identified on the basis of conventional imaging that we thought might be appropriate for metastasis-directed therapy. Now, granted, this guy had a PSA of 100, which makes me think we should have never been trusting this bone scan that showed this one probable metastasis. But his CT scan was also negative, so what do we do with this guy? Well, luckily, we had just started to have PSMA PET, and it turns out he had hundreds of marrow-based lesions, and we just couldn't appreciate them because they hadn't caused enough sclerosis to show up on CT or bone scan. And then there's sort of these intermediate patients that have they have a bit more disease than just that solitary site of disease, but it's still relatively limited. Here was a patient who does have M1A disease, so he is starting to become metastatic. He has these retroperitoneal lymph nodes. He also has some pelvic lymph nodes. He also underwent SBRT to those sites of disease, and he came back, and this is always hard to see on the projection, but he had disseminated subtle bone lesions on his follow-up PSMA PET. And he progressed right through his therapy. So we do have to be able to select these patients properly. I don't know that we entirely understand how to do that yet. And then, of course, we have to know those things that aren't actually cancer so that we can avoid them and not overtreat them. So things like rib fractures, compression fractures in the spine, those things can have PSMA uptake. Ganglia are sort of famous for having PSMA uptake, and we have to know the anatomy of those to avoid, again, kind of overtreating them. And this is the most famous one, the celiac ganglion, which looks just like a retroperitoneal lymph node. And then even things like Paget's disease, or there's so many things in the bone that can have false positive PSMA uptake. It's really a little bit of a minefield. And post-radiation changes can have PSMA uptake. So even after we've treated a patient, our understanding of how to sort of follow that treatment response on PSMA PET is going to have to be nuanced, and we still have some work to do there. So with that, there are already multiple indications for diagnostic PSMA-based imaging, including the ones that we talked about. There's data from pivotal clinical trials that should guide our approach to interpretation of PSMA PET scans, and the high detection efficiency of PSMA PET. In terms of how it is guiding therapy, there's still some uncertainties there. I'd like to thank the 1 million people that I work with that helped generate all of this, and with that, I'll wrap up. Thank you.